Hello, everyone. Welcome. We're just going to give another few moments so that folks can join from the waiting room. All right, it looks like we have a lot of folks here, so we'll be getting started. Thank you all so much for joining, whether it is morning or afternoon, depending on where you are joining from. Just wanted to start off by sharing a couple kind of housekeeping suggestions and rules. So this is a meeting style webinar, and so we just would ask that you please keep yourself on mute until we get to a time of questions, and then there might be some opportunity to come off mute. This webinar will be recorded and will be shared out on our website for future viewing. If you do have questions, we have a live Menti, which is a just like a online question platform that we will be sharing the link and QR code throughout the presentation. So if you have questions, we do ask that you pop them in the Menti. If that's not working for you, you can pop them in the chat and we'll make sure that we've collected those. We'll try to get to as many as we can, but might follow up with some further correspondence to get to any that we didn't have time for. We are going to have a survey presented at the end of the webinar. Just is an evaluation for us, helps us know what was helpful for you all, and is just really useful. So we would ask you to spend a few minutes at the end of this presentation to complete that survey. And then if you have any direct questions that you want to have a later follow-up, please email maricopahealthmatters@maricopa.gov. So that will ensure that we have any of those questions to connect or chat further will be saved there. All right, and with that, we are going to kick it off. Welcome to CHNA or CHA 101 about the Community Health Needs Assessment in Maricopa County. Head to the next slide. Wanted to start off with some introductions. So meet the Synapse and CHNA team. My name is Annie Damian. I use she, her pronouns. I'm our Community Health Assessment and Impact Supervisor. I have a fantabulous team, including Tiffany Tu, Pearl Gore, who are Community Health Impact Specialists. Hamza Rafiq is our Community Health Epidemiologist. Jessica Francis, who will be co-presenting with me today, is our Community Health Assessment Coordinator. And Lihem Iyasu is our Communications Coordinator. Now, there's a lot of other folks who work on our CHNA, but this is really our core team. We couldn't do the work we do without everybody here. All right, so our roadmap for today, we're going to talk a little bit about Maricopa County and the Maricopa County Department of Public Health, or MCDPH. We're going to talk through the infrastructure for the CHNA. We're going to look at our 2023 CHA roadmap, materials, and methodology, as well as our 2023 CHA survey, equity-based outreach. We'll wrap up with our prioritization process and where we're heading next, and then have time for that Q&A. So as we get kicked off, we've shared a tiny bit about ourselves, but we want to know who's in the Zoom. There will be a poll that pops up. Please take a moment to respond just about what sector you represent, what your population size you serve, and a couple questions about collaboration. How are we looking on responses? Alrighty, wonderful. Okay, so it looks like we have about 40% of our attendees from our local health department. We have some public health nonprofit, municipality, academic, education sector as well. Population size, we have quite a few who answer 1 million plus, but also some smaller jurisdictions, which is exciting. It looks like about 60% of respondents do work collaboratively with hospital and healthcare systems to conduct their job, as well as about 50% working with community coalitions. So very exciting. Thank you so much for participating in that. We can head on now to the next slide. So this is going to be really your one-stop shop for submitting questions. So you can pull up this Menti. You can pull it up in a web browser. You can scan this QR code, and you can submit as many questions as you like. So some of them we will, hopefully be getting to throughout the presentation, and we will put this up as a reminder throughout. But that will just help us kind of keep track of what all you have on your mind. I just popped a link to this in the chat as well. All right, let's dive in. So meet Maricopa County and the Maricopa County Department of Public Health. We are, next slide, please. Our vision is to create a healthy, thriving Maricopa County for all. Our core values include excellence, collaboration, resourcefulness, accountability, and integrity, growth mindset, and inclusiveness. And so these are things that we really try to weave into a lot of our approaches for working, internal department to department, as well as in our communities. Next slide, please. We are the third largest health jurisdiction in the United States. We serve over 4.5 million residents. We have 24 cities, towns, including tribal land and unincorporated communities. And we are the fourth most populous county in the US. Maricopa County is highlighted in red here, and we hold 62% of the entire state's population. So it's a big county. We have a lot going on, a lot of fantastic diverse communities, and so just wanted to kind of start off with that. Next slide. Looking at our demographics, we have kind of close to 50-50 sex male-female split. Looking at our ages, our highest populations do include our 25 to 64-year-olds. We do have about 20% of our population is 0 to 14. Language is the predominant language, English is the predominant language spoken at home, followed by Spanish. And then looking at our race and ethnicity breakdown, we do about 54% white non-Hispanic, 5% Black non-Hispanic, 4% Asian, 1.5% American Indian, and 31.5% Hispanic. So as mentioned, this is a huge county with a lot of folks. And so in 2020, the Public Health Department designated 5 distinct regions. So this is a map showing those different regions. By dividing up the county into these public health regions, we can highlight diversity from urban, suburban, and rural communities. This really helped inform our COVID-19 response. So how we were sending out, our different testing and vaccination clinics and resources. We also have a public health liaison for each of these regions that connect the work of the public health department back out to our municipalities and cities and towns. So this is one way that for a large county and large population, we've been able to really provide that more specialized and tailored care for our residents. So now let's talk about infrastructure for the community health needs assessment. So just to give a little background, probably a lot of you here know what a CHA is, but it is a comprehensive data collection of a community to identify strengths, needs, and health priorities. So the CHA is a requirement for public health departments that are accredited through FAB or the Public Health Accreditation Board. And what the CHNA does is it also establishes priority for the development of the CHIP, or the Community Health Improvement Plan. So this is really kind of our the information from the CHA steers where we're going to go as a health department and setting those priorities based on community input and not just what public health as a department is focused on. For healthcare entities, it's a requirement for nonprofit hospitals and federally qualified health centers as established by the IRS and HRSA. And what this does for our healthcare centers is establishes priority for development of their implementation strategic plan. So it really provides that resource for our healthcare partners to look beyond just the services that they provide on the day-to-day, but what are the needs identified by their communities, and how do we tailor our medical approach to preventative healthcare needs, connecting folks out to other resources if this specific hospital or health center doesn't specialize in that area. So it's a really great way for those that kind of public health and healthcare connection to really come together through data. We have our Coalition for Health Assessment and Improvements. It is called the Maricopa Health Matters Initiative. So as County Public Health, we're the convening agency. We have two different wings that we support. One is the Synapse Hospital and Healthcare Partnership. So that is a coalition that myself and my team leads. So we work to create health assessments, not only for the county overall, but for individual hospitals and FQHCs. We also have the Health Improvement Partnership of Maricopa County, and that is really our improvement plan wing. It's really made up by community-based organizations, nonprofits, community members, representatives, and so that kind of is our grassroots partnership wing to help inform the work that we do all together. So to dive a little bit more into this, with Synapse, we are a coalition who collaborate to collect data. So instead of having each nonprofit hospital and FQHC do their own surveys and data collection, we work together under a contract to collect that data in a unified way. So we'll be getting into it a little bit more in this presentation about how that really helps strengthen the amount and the quality of data that we collect. What it helps too is really make sure that we're aligning our understanding of our residents across different agencies. So here to the right, we have a list of our current Synapse partners. We head to the next slide. Another visual representation of our Synapse partners. So at the moment, we have 5 nonprofit hospitals and 5 federally qualified health systems who are partnered with our Synapse Coalition. We also have Vitalist Health Foundation at the table as a philanthropy partner. Next slide. All right, so talking a little bit about the HIPMC or Health Improvement Partnership. So this really is our community partner wing of the Maricopa Health Matters Coalition. So it's a diverse group of residents who live in or serve Maricopa County residents. Members participate in data collection of the CHA as well as data-driven decisions. So this is really the group that is leading the Community Health Improvement Plan, giving voice to rural, urban, and under-resourced communities. So the mission is to impact critical health issues where we live, work, learn, and seek care, to empower communities to participate together and collaborate to reach optimal health and quality of life for all. All right, next slide. So a little bit more about how it works with our CHA partnership and having so many healthcare partners involved and the county. How do we do this? So we know that there's a lot of different methods that folks use, across the country. So we do a bit of a hybrid approach where we have a unified data collection and then independent reporting for our partners. So we typically start where the star is. So working in partnership with our Synapse partners and HIPMC, we develop the CHA survey and focus group questions, making sure that the questions that we'll be gathering will align with the informational needs of these different agencies, but really always guided by that kind of public health foundation approach. As the county, then we work to conduct the CHA survey and focus groups. So we're the primarily responsible for ensuring that we get good representation, that we're in charge of all of the outreach and all these different exciting techniques that we'll be diving into in a bit. We also work to analyze data indicators for every single one of our healthcare agencies. So some of them have the entire county as their service area. Some of them have specific zip codes kind of as the majority of residents that they serve. So our epidemiology team crunches all of our hospital discharge and death and population data to really give that specific look at what are kind of the health impacts of that community. Then we work individually with each of those agencies to help prioritize health needs. This is one of my favorite parts. We get to really come together with the kind of with the partners that specific agency has identified to look at data, to talk through criteria and alignment for mission and values with that agency, and to set what those top health priorities are that agency will be focused on for the next 3 years. Once those needs are prioritized, we develop the CHNA report for the partners, and then they take that to create their own strategic plan. So that's kind of on a partner by partner basis, but we do this process as well for the county. So that's really also mostly what we'll be focused on today, but just kind of wanted to give that visual of how it works. It's all based on a 3-year contract, so we do have funding that is provided by those healthcare agencies. As a reminder, if you just joined us or if you need the link again, please ask your questions here on the Mentee. I see some questions coming in, which is wonderful. Question I'm going to actually respond to right now is, are the Synapse member organizations the same as in the HIPMC? How do you coordinate that some groups do not overrepresent these efforts? Fabulous question. So the HIPMC has and this is, we have another webinar coming up for CHIP 101, and so we're going to be able to get into that in more detail. But the HIPMC has a body of volunteer steering committee members, and they are the voting members of the HIPMC. They represent a wide variety of different sectors, geographies, etc. There's one seat for a voting member on the HIPMC steering committee that is a Synapse HIPMC liaison. So that is an individual who is one of the Synapse partners, and they have one of the, I believe, 15 voting seats. So that is one way to ensure that Synapse is connected, has a seat at the table, but we don't have an overrepresentation there. And then when we have quarterly partner meetings with the HIPMC, we do encourage our Synapse members to attend and to join. But again, a lot of the meat of the decisions are guided by that steering committee. So that's one of the ways that we ensure the kind of overall representation and shared power. All right, heading on to the next slide, I am going to pass it off to my colleague Jessica to kind of dive into some of the details of our CHNA.
Hello, everyone. So as Annie said, I'm Jessica. I'm the Community Health Assessment Coordinator, and I'm going to be going over the timeline, the materials we provided, and the methodology for conducting the survey. So our general roadmap that we had was we started planning for this cycle back in July in the year of 2022. We had our pilot survey. We had focus groups for our pilot surveys in order to make sure that we were asking culturally appropriate questions and that they made sense to community members. We officially opened the survey, launched it in March. At that same time, we were also conducting our focus groups. So our CHNA survey is more about collecting that quantitative data, whereas our focus groups is about collecting that qualitative data where we get to hear individual people's stories that help supplement the quantitative data we collect. From July to September, we were doing a lot of paper data entry. As we will go into, this survey was available in many formats. So we were doing data entry, we were analyzing and cleaning the data. Just recently, at the beginning of this year, we conducted our key informant interviews, and we are currently planning on publishing the rest of our reports between now and fall of 2024. We do already have 3 of our reports out, and the rest is to come. So behind our data collection methodology, we had a community survey that included in-person and virtual recruitment. We made sure to set and monitor recruitment goals so that we had representative participation that accurately, closely reflected the demographic makeup of Maricopa County. And we made sure that the survey tool was designed with accessibility in mind. This included paper format, large fonts, having it available online as well, and that people could access it with their screen readers. Our focus groups, we had both in-person and virtual. We made sure to recruit for specific populations, many that are underrepresented in a lot of the data that we see. We had it available in English and Spanish. And for the focus groups, we had that conducted by a separate county vendor. And similar as well for the key informant interviews, we had virtual interviews. We made sure that our recruitment, those who were invited to do the key informant interviews, that they represented all of the different regions of Maricopa County or all of Maricopa County, and that the populations they served were representative of the focus populations that we really wanted to hear from. As well, again, it was conducted by a separate county vendor. So this is kind of an overview of data collection that we've done throughout the years. You can see back in 2012, we started with a modest 973 surveys collected, and that was in providing the surveys in both English and Spanish. And we also had it available in paper. And as you can see throughout the years, we've progressively been able to add more features. We've been able to provide grants so that community partners could help us with outreach. So if you see all the way on the right side for 2023, we were able to add, have the survey in virtual formats. We made sure we had a regional approach, and we had additional languages to English and Spanish, which resulted in us being able to collect over 18,000 surveys. As mentioned previously, we provided this survey in both electronic and paper format, and we also made sure that all our participants in either format had access to a resource page. We wanted to make sure that instead of just asking participants what are health issues, what are concerns that you have, and then just taking their data and leaving, that we also are providing them resources in case any of them were in need of assistance. So these are the 13 additional languages that we had the survey available in. And this reflects the languages that are commonly spoken in Maricopa County. Some data collection ethics that we explained to all those doing data collection was we wanted to make sure that all participants knew that this was a voluntary survey that they could take, that they could just answer as many questions as they felt comfortable doing so. We wanted to make sure respondents had privacy and confidentiality, especially when we were administering these surveys in person. We didn't want participants to feel unduly pressured or to answer a certain way or to please the person who was providing the survey. This goes into the next point of avoiding biasing participant response. We made sure that we provided appropriate survey gifts depending on the venue. We recommended to everyone, and as research shows, that we don't want to provide just money as a form of compensation. It tends to lead to sometimes, especially virtually, having bad actors take the survey just for the sake of getting that money. So we had various types of giveaways that we gave that were related to health. We had like an emergency giveaway that included items like a little hammer, a flashlight, and Band-Aids. We had a healthy eating giveaway, which included a salad shaker, bamboo utensils. So we made sure to provide compensation such as those giveaways. And of course, we wanted to make sure that when surveying minors, that everyone received their parental or guardian verbal consent. So we made sure not to provide the surveys in schools, but just when we were out at events, just being able to ask a minor's guardian if they could take it. Some of the promotional materials that we had included business cards, postcards. We had 8.5 by 11 flyers, and we also had very large glossy posters that could be easily seen from far away. And then all of our outreach partners, including anyone online, had access to our virtual materials, which also included flyers, social media graphics, email templates, and a checklist with different ways that the survey could be promoted in your community. And then we just included a video. We don't have time to watch it today, but we highly recommend. It just gives a little glimpse into the CHNA and the overall cycle. It's available on our website of maricopahealthmatters.org in both English and Spanish. So now to go more into our equity-based outreach. Some keys to success that we had were clearly defined participation goals and routine monitoring of the data that was coming in, engaging our local community organizations to assist us with collecting the data. We mobilized and relied heavily on our public health staff, volunteers, and university students to collect data through events and tabling. And we also had a comprehensive communications plan, which included that online and physical toolkit we showed earlier, having a consistent messaging schedule. We had a CHNA email list where anyone who signed up was getting constant updates about what was happening throughout the survey cycle. And at the participants also had the option to sign up for those updates as well. These are some of the focus populations that we were trying to reach out to with our focus groups and with our CHNA survey. Some of these focus groups include people living in rural areas of Maricopa County, veterans, LGBTQ+ individuals, people living with HIV or AIDS, Native Hawaiian Pacific Islander individuals, Black or African American individuals, and tribal or Native American individuals. So the reason why we had this targeted outreach is because in the past, for our 2021 CHNA, we did see underrepresentation from our Hispanic or Latino X communities and from our African American or Black communities, and especially male individuals. And the purpose of the survey, when we are trying to figure out what are the top health needs of the community, we want to make sure that we are getting a representative sample that closely matches what we have here in Maricopa County. So for this year, we were able to get a total of 18,297 survey participants. And from our focus groups as well, we had 366 participants. So what you can see here at the bottom is in orange are the statistics for our survey participants, and dark blue is for our focus group participants. This year, we were very excited that we had a comprehensive gender identity question so that we were able to get data on not just our cisgender men and our cisgender women categories, but also those who identify as a transgender man, transgender woman, or as non-binary or genderqueer. And then when we looked at race this year, we were very excited to see that we were able to not only increase, but even double the amount of outreach that we got compared to previous years for our Black or African American demographics populations, and for our Hispanic or Latino X populations. And again, as on the previous slide, our dark blue shows the demographic profile of Maricopa County. The orange shows how much we were able to recruit from those populations for the survey, and the teal shows how much we were able to recruit from those populations for the focus group. I just wanted to note for the ages for the survey respondents below that for our focus group residents, you see that there is a large percentage, that 58.3%. That's just because for our focus group recruiting, the way we reported it out was we had the ages of 25 to 64 grouped together. So you might be wondering, how did we set our recruitment goals? We had an overall goal of 15,000 participants, and this was set on what we were able to achieve previously in past years. Rather than greatly increasing how much we wanted to recruit this year, we made sure to focus on making sure that it was a diverse recruitment that as close as possible reflected the demographic makeup of Maricopa County. Our goals for each demographic were calculated based on available population census data. And you might be wondering, for populations where no census data was available, we made sure that we set minimum goals for 50 for each demographic population, and then we made sure to scale up the size of that minimum to match the region. So as you saw, we had that 5-part regionalized plan where we split the county into 5 different regions. So if our minimum size for one region, our smallest region, was 50, for example, we wanted to be able to get 50 Asians to take the survey in that region. For our largest region, if that was 4 times larger than our smallest region, then accordingly, we would set our minimum for 200 for that region. This kind of goes into the consistent messaging that we had into the community. Each week, we would regularly report out on how much we were able to recruit and what those statistics look like for the overall survey goal for each region by race and ethnicity, and by specific focus populations that we were trying to recruit from, such as our veterans, those identifying as LGBTQ+, and those living with disabilities. So this graphic that we're showing on the screen here is a progress update from about 1 month into our data collection in April of last year. And of course, we wouldn't be able to collect such diverse representation without the help of our outreach partners. So we had 23 grant-funded outreach partners who helped us with promoting the survey in a culturally appropriate way to different populations in Maricopa County. And we're especially grateful for them because, as many know, there are a lot of populations who have been historically marginalized or hurt by government policies. And so it was very helpful being able to have these outreach partners be our liaisons and be that trusted person to know how to promote the survey in such a way that participants don't feel like they're being coerced and they don't feel like there's going to be any harm coming to them. So this is just some feedback that we got during our survey recruitment. We had a question at the end of the survey that asked, is there anything that you would like to share about your health or the health of your community? We had one participant say that they love that there's more events where they can have their voice heard. And another participant, as you can see here in the bottom right corner, said, thank you for doing this assessment. It's very important and there's complex subcategories to cover. It's good to see the inclusiveness of many traits and genders. So just some event statistics, we did 18 weeks of data collection, and during that time, we were able to attend 187 events throughout the county. We had 68 staff and volunteers who were working around the clock, which led to 1,300 plus hours being spent at events. And we were able to put together 4,500 giveaway kits to provide to survey participants at these in-person events. This is a map of all the locations that we were able to do recruitment at throughout Maricopa County. So as you can see, we went even as far out as Gila Bend, and we did our best to recruit from all the 5 different regions of the county. And we do have our CHNA survey results available on our website, maricopahealthmatters.org. As you can see on the left, we do currently have released our focus group report, our key informant interview report, and our community survey report. And coming soon, later by fall of this year, we'll have our community status report, an in-depth report on our prioritization process to get those health priorities, and our overall CHNA dashboard that will be a nice summary of all these various reports. Additionally, on this dashboard and on our website, you can see that we have community profiles for the overall county and for each region that go a little bit more into the data breakout of various questions, such as which health issues have the most impact on you and the people you live with or care for, and how would you rate community strengths and assets in your community. So before we go to the next step, I just wanted to see if there's any questions. Did we have any questions, Annie?
We had a few questions, I think, in response to the resource page. So looks like there's some interest in developing a spreadsheet of family resources. We had somebody put in the link for findhelp.org, which is where we got a lot of our resources that we listed on that spreadsheet. So I can pop that in the chat. And then somebody shared that in Tucson, there was a book of all family resources that was revamped every few years. So just some really good some feedback and questions about those resources.
Awesome. Well, thank you, everyone. With that, to go over our prioritization process and next steps, I will hand it off to Annie.
All right, thank you. I'm just putting that feedback in the chat. About the findhelp.org. So what happens next? We have all this great data. We're so excited to be sharing it out and, kind of packaging it based on geographies and populations and those type of things. But what are we going to do with it, right? Like it is definitely our, it's really important that we, not just take information from folks, but that we're actively doing something about it. So that's where we shift into our CHIP, or our improvement plan. And to do that, we follow the next phases of prioritizing the information that we have. So this is a lot happening right here. But we wanted to kind of make this available, especially for our folks who live in Maricopa County, to see kind of like where we've been so far for distilling this information down to priorities. And also for folks who, maybe if you're joining in from a different state or county and are looking to maybe do something like this next. So as you all know, there's so many different health indicators and social indicators that one could prioritize to work on strategically for the next 3 to 5 years. So it was really important for us to engage our community coalitions, Synapse and HIPMC, in helping us to decide how we're going to prioritize that. So we had both our HIPMC steering committee and our Synapse coalition work on developing a ranking tool, which I will be showing in a few slides. But basically looking at what are the categories for which we can, assess the data and determine if this is something that is, feasible, realistic, what the level of impact, in order to do something about it and to select that. We then took 165 priorities. Our epidemiology team worked on crunching a ton of data, population data, survey data, focus group data, key informant interview data, to really see what was rising to the top. So all this data was evaluated through a data matrix, and our CHNA committee reviewed the findings. So things that really came to the top were items that were, referenced multiple times across these different sources, as well as when we saw disparate impacts based on population characteristics. So we had 20 priorities. So we took those 20 priorities back to our Synapse and our HIPMC steering committees to use that ranking tool that was developed. And so we presented data, we presented population and survey data and quotes, and had our committee members rate each of those different data priorities based on that ranking tool. That led us down to 13 different priorities. And so at that point, we brought that back to the larger community. Every quarter, we have a partner meeting for our HIPMC, and that's where we have steering committee members attend, but also it's always an open event to have folks from across the community come and participate and learn and share their feedback. Because this was a really critical part of our prioritization, we wanted to ensure that, not only have we been getting representative data throughout this last, year and a half that is underlying these decisions, but that we had a diverse group of folks in the room. We did really intentional recruitment for that June quarterly partner meeting. We we did phone calls to all of our 23 partner organizations that helped collect data. We really spread the word far and wide to have folks come and be a part of this. And so we ranked the top issues. So from the 13, we also had these presented in front of the community, and they were rated across the 4 different criteria that, again, I'll show it to you in just a moment. That got us down to our top 3 to 5 priorities. So what comes next? We have our community health needs assessment that we've had several of the different reports that have been published already, but as Jessica mentioned, we're pulling all of that into kind of a summary dashboard that's interactive, and it's easy to kind of find based on these priorities where that information is. HIPMC is going to work to develop strategies based on these priorities, especially for our September 4 quarterly partner meeting. I'll give a little bit more details there. And we're looking for end of the year to have the CHIP published. So happy to share more details, but just wanted to kind of give that pathway. Again, so much of our community input is reflected throughout these stages because it's based on that data that that was a priority to have representative, authentic community voices in. All right, next slide, please. Also, as we look at this data, we wanted to use 3 different public health lenses. One was community strengths and organizational capacity. So what already exists in the community? What are the strengths among the organizations that are going to be working on these issues? So for example, 55% of survey participants rated access to parks and the opportunity to participate in religious or cultural events is very good. So this is helpful data for us to see what are those strengths already in the community and how might we, partner and leverage and work to really use those avenues as we work on improvement strategies. Another one is health behaviors and health outcomes. So that's where we look at a lot of our data from our behavioral risk factor surveys. We look at our survey data. We look at our population health outcome data to really understand what's happening and what are these long-term impacts. Then, of course, we have our health equity, systems of power, privilege, and oppression as a lens that we look at. For example, over 6,500 survey participants recorded encountering discrimination in the past 12 months based on an aspect of their identity. So not only was this something new that we were asking in our survey, but also as we captured more comprehensive data on race, ethnicity, sexual orientation, and gender identity, it gives us that opportunity to really look and see how folks are experiencing different health outcomes based on aspects of their identity. So wanting to kind of show you what we showed to our community members. We had, based on each of our priorities, these are some of the examples of the data. So for example, access to healthcare. We gave a couple stats from the census about the number of folks who are insured and uninsured in the county. A stat from our CHNA survey about access to medical care when needed, money to pay for essentials. And then one important question that we liked that we reframed this year, instead of saying what is a barrier to care, and then us filling in the gap for, well, how would we fix that barrier? We just asked people what would help you get the care you need. Pretty simple, pretty straightforward, really trying to honor that people know for themselves what they need. So evening weekend appointments, lower out-of-pocket costs for services, et cetera. Those were some of the top things that came up. So we also have our housing and homeless and our social isolation examples, just showing how we can do some geography data. We also split some of these responses by race and ethnicity, as well as focus populations. So for example, with social isolation, as far as of our subgroups who rated connection with others as poor, folks experiencing homelessness had the highest rate of kind of that poor connection outcome. We also will include quotes like this one here about that either came from interviews or focus groups or our surveys. So we presented all of this data and we gave folks the opportunity to kind of rate each of the indicators based on this matrix. And as a reminder, this matrix was co-created with our HIP-MC steering committee, with our Synapse partners, with public health. So we had relevance, impact, alignment, and feasibility. And all these sub-questions were just guiding questions for people to kind of focus in on how they wanted to rate them. So the next slide, we used Menti for everybody to get the opportunity to rate each of these indicators. So for example, for access to healthcare, folks could rate, there was a sliding scale for relevance, impact, alignment, and feasibility. And we were able to take the averages of those and come up with that final measure. So here you'll see the overall average for this indicator based on the average across people and across the 4 criteria was 3.8 out of 5. So looking at all of that, we ranked the top health priorities based on the ratings. So we came up with mental health, access to healthcare, and access to food as the top 3, and then substance use and housing homelessness as the top and within the top 5. So heat and transportation were also a few of the issues that we saw that we focused on. But as you can see too, there's kind of a bigger gap between those average scores. So we have this data, now what? Now we move into the community health improvement plan. So this is a plan that's completed every 3 years in line with the needs assessment. It is a requirement for public health accreditation. And really it's setting those priorities, coordinating and targeting resources, to help collaborate with the actions taken by community organizations and community members. So there is an opportunity for us to dive, for you to join us and to chat more about that. I actually have 2 more webinars coming up, which is super exciting. So if you've had a good time today, join us again. I see we've had a few questions in the chat about Synapse. How is it funded? How does it work? Lucky for you, we have a Synapse 101 webinar coming up on August 5th. So you can scan the QR code or go to the bit.ly link to register for that. We'll kind of get into some of that nitty gritty of how our contracts work and how we do our timelines and those kind of things. To answer the question I did see in the chat, Synapse is funded by the nonprofit hospitals and health and FQHCs who work with us. It is at a much reduced rate than perhaps these healthcare partners would find if they were to contract out those services. But we can get into all those details in the Synapse 101. And then CHIP 101 is going to be led by our fearless CHIP team, Irene and Tao. That's on August 8th. So a few things that are really exciting is that it is CHIP season. We are looking at the priorities. We're looking at what we can do. We're ready to set criteria. And we want to invite those of you in Maricopa County to be a part of that. So please join us for CHIP 101. If you're interested in kind of checking out more about what's been going on, and we share a lot of stuff. Again, having our communications coordinator, Liam, is, as far as recommendations for anybody, any other jurisdictions doing their CHA and CHIP, you need a Liam. She keeps us moving on communications, all of our stuff looking really good, keeping our website updated. And I think that's a huge part, having that transparency. So visit maricopahealthmatters.org to check out some of those stuff we've been doing. Again, if you want to set up a time for us to, chat more one-on-one, please email us at maricopahealthmatters@maricopa.gov. And all right, I think from there, do we have any last slides before we do questions? Sweet. All right, so as a reminder, hop on this link for menti.com. I'm seeing we have some fabulous questions. And I'm going to start from here. And then depending on how much time we have, we might be able to open it up further. Okay, so we answered Synapse, how's it funded? We had a question. Are there any metrics set for the priorities by the CHAs, by the CHNAs or the CHAs? Are there any metrics set? I would welcome whoever's question that is, if you'd like to maybe give a little bit more detail, but we will be setting metrics and priorities for the CHIP. So those criteria and those goals for the improvement plan. And then we did have those kind of the metrics and criteria that were developed in the ranking tool that we used to assess the data. Does that answer the question, or is there anything else I can clarify? Feel free to jump in the chat or come off mute if you like. We have a question. Is your CHA and CHIP teams different groups? That is a fabulous question. So we do have kind of like under one umbrella our community health development team. But the slide I showed at the very top, which was like our CHA Synapse team, there are 4 of us who work specifically on the needs assessment for the county, as well as our Synapse partners. And then we have another team that with 3 individuals who they facilitate the HIP-MC coalition and the development of the CHIP. So they are different teams. We work together a lot because the work really informs each other. But yes, there are 2 different leads and folks working on it, which is also really helpful because, as you know, these are big coalitions, these are big projects. So definitely recommend that alignment, but it is nice to have those different focus roles. What platform do you use for your graphics? They look great. That is such a nice compliment. I am happy to, let's see, Liam, you can jump in. We can Canva, thank you. So we do a lot of graphics on Canva. We do a surprising amount of stuff in Microsoft Word, like surprising amount of stuff in Microsoft Word and PowerPoint. But otherwise we, yeah, just kind of some, a lot of those like available tools, and we're always trying to improve to making things more clear, more, more accessible, more easier for different levels of our community engagement. Okay, I think we had some